More than a year into the coronavirus pandemic, we'll explore how the long-term care hospital has evolved, as well as discuss the experience of long-haul patients, those individuals who no longer have an active virus, but still have complex symptoms caused by the virus. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, Executive Speechwriter for the AHA. In this podcast, Rochelle Archuleta, Policy Director at AHA, speaks with Jim Prister, the President and CEO of RML Specialty Hospital in the Greater Chicago area. Jim also serves on the AHA Board of Directors and chairs the AHA's Post-Acute Care Steering Committee. We're also pleased to have Dr. John Votto, a pulmonologist and former CEO of the Hospital for Special Care in New Britain, Connecticut.
Hello, everyone. I'm Rochelle Archuleta, Policy Director with the American Hospital Association. On today's podcast, I'm joined by two leaders to discuss the experience of the long-term care hospital field during the COVID-19 public health emergency. Welcome, Jim and Dr. Votto. We really appreciate the both of you joining us today. Before we begin our discussion, for those listeners who are less familiar with the role of a long-term care hospital, there are 360 LTACs in the United States, and the AHA represents 250 of those. LTACs focus on treating the highest acuity patients transferred from a general acute care hospital who are expected to need a long subsequent stay in a hospital. In fact, for long-stay patients, LTACs have an average length of stay that is greater than 25 days, which is about 5 times the average found in general acute care hospitals. Throughout the pandemic, many LTACs have played a key role in their communities by treating some of the sickest patients with active COVID, patients with complex COVID recoveries, as well as other hospital-level patients transferred during a local COVID surge.
Rochelle, thank you for the opportunity to participate on this podcast this afternoon, and I'm very appreciative of all the efforts that the American Hospital Association has taken on behalf of the LTAC industry over the course of the last year. As we get started in the podcast, I would be remiss if I didn't thank the tremendous staff that are at RML also, taking care of the patients that we have been entrusted with over the course of the last year during the pandemic and during the ups and downs that we've had over the course of the last year. And then also the other members of the LTAC industry nationally who have really created a system where the healthcare system can rely on the services that were being provided really across the country to both COVID positive patients. And as we'll talk about in a little bit, some of the patients that are now recovering from the long-term aspects of COVID disease. As part of this, I think it'd be helpful to describe RML in a little bit of detail, just so you know what RML is all about. We are an LTAC system located in the Chicagoland area. We are licensed for 184 beds between 2 locations. One location is in a western suburb of Chicago. The other is on the west side of Chicago, close to the downtown area. We have really been known as an LTAC focused on ventilator management over the last 20 plus years. About 60% of all of our patients come to us on ventilators. We have 65 hospitals that send us patients. We're a very large regional referral system in the Chicagoland area and have a very high complex patient population that we are dealing with. So that describes RML in a little bit of detail. If you have any questions, I can address those later on during the podcast.
Thanks, Jim. That's a great description. For now, let's turn to our first topic. Since the COVID-19 fight intensified last year, how has the experience of Chicago COVID patients and hospital partners evolved?
That is a very loaded question, Rochelle. It's hard to believe that it has been a year since this whole process really got initiated. And you had a couple of qualifiers in your description there, because I think it's important to really recognize what has transpired over the last year and how things have changed. We were in a market that was hit early on in the first phase of the COVID pandemic. And believe it or not, it has been almost a year since we activated our first COVID unit. Let me bring you back a year and try to identify for you what really transpired here in Chicago. And I broke it up into 3 different phases. The first phase is really what I would call our preparation phase that occurred beginning in mid-February last year, 2020, and really through the end of March. What we found is that as we reached out to our referring community hospitals that were sending us patients, a growing and significant demand for relief from their ICU. Most of the key referral sources here in Chicago were preparing for really the onslaught of COVID patients. There was a lot of fear. Would there be capacity in the system? Would our ICU capacity run out? What were we going to do to really offload some of these patients? So when that fear started and really efforts began in Chicago, RML extended ourselves out to our referring communities and really engaged in a much higher active management of ICU level patients. We were very fortunate because we opened up a new 25-bed unit in early January. So our preparation really coincided very well with what was happening from the pandemic and the needs in the community. We immediately filled those additional 25 beds with ICU level patients and started becoming a relief valve for the referring hospitals as they were dealing with active COVID patients. We made a very significant decision in the early phases that we would not get into the COVID sort of, if you will, management of patients. And then that lasted just a little bit of time, not as long as we would have liked, but by the end of March last year, we ended up opening up a COVID unit in our Hinsdale location, and then subsequently a couple of weeks later in our Chicago location, and started admitting patients that were on ventilators and were active COVID, had active COVID disease. We quickly filled those 42 beds. We were engaged in communications on a day in and day out basis with our referral sources. There became a frustration because there was not a lot of relief. They were converting med-surg beds, other step-down beds to COVID patients, and we were taking the most significantly ill patients as we had beds free up during that particular phase. Then we got into the spring, early summer, and COVID became less of a ongoing day-to-day management. We made it through the summer with having still COVID positive patients being admitted, but they were transitioning from being vent dependent to having high oxygen needs and the Optiflow programs that were being requested. And then we hit the fall, and then so we went back into another spike in the fall. And again, I think Dr. John Votto will be talking about the transition that were made in the management, clinical management of these patients. But our focus really never wavered very much from being a resource to the referring communities. So in the fall, the spike occurred again, actually to as high levels, in some instances higher levels than we had in the spring of 2020. And we became a resource again. Hospitals were having significant challenges really getting their patients through the admission process. And we opened the doors again and started taking a much higher acuity patient again than we were used to in the past. What we found in this second wave, though, is that these patients were sicker. Their comorbid conditions were more substantial. The recovery process was taking longer. They had more comorbidities as they were moving through the recovery process. And what we found is that we have actually been one of those hospitals with waiting lists. We have been trying to adjust as much as we can. There's been significant staff shortages here in the Chicagoland area. We've been running well above capacity levels for almost a year now. Our staff are tired. The relief that hopefully will be not too far in the distant future will be of benefit to the team here at RML. And we really want to be prepared for what may come again, unfortunately, if the variants do come back in full force again. So that was in a nutshell what we've done over the course of the last year, and be happy to address any questions that you may have.
Thank you, Jim. That was a great overview of how the situation evolved over the months, as well as RML's responsiveness to the situation. Next, let's turn to Dr. Votto and his insights on long-haul patients. And let's begin with a bit about the Hospital for Special Care.
Thank you, Rochelle, and thank you to the AHA for inviting me to talk a little bit about this very interesting topic. So the Hospital for Special Care is a 228-bed LTAC in Connecticut. We actually have two campuses, 200 beds at the main campus in New Britain and 28 beds at the satellite campus in Hartford, Connecticut, between the two major hospital systems in Hartford. We are known as a respiratory hospital, but we also have a rehab unit as well as other specialty units, including a cardiac unit and a respiratory weaning unit, and a pediatric LTAC as well, which is pretty much the only one in the country with an LTAC with a pediatric unit. Anyway, we are very familiar with respiratory disease, having about 100 ventilators on any given day. So that's what we do, and so COVID-19 patients sort of fit into what we were very familiar with over the last 75 years. And this population of long-haul COVID patients, and I should define long-haul. So there's this feeling that there's an acute phase to COVID, which is usually considered up to 4 weeks. And then there's this ongoing symptomatic COVID phase, which is usually considered 4 to 12 weeks. So that would be a long haul patient. But now what we're finding out with these patients is that long haul is often much longer than 12 weeks. And there are patients that typically present in the post-acute setting with the same symptoms that the long haulers present with, which include often fatigue, dyspnea, chest discomfort, cough. But also what we're seeing in the very late phases after 12 weeks is a persistence of symptoms consistent with PTSD, impaired memory, and anxiety. And the numbers are bothersome. Fatigue is seen in 15 to 87% of patients, dyspnea in 10 to 71% of patients. That they're all over the board, but there's actually a very high percentage of patients that continue to have symptoms. PTSD and impaired memory are in the 20% range for all patients, but what they basically have in the long-haul population, what we're looking at is the post-ICU syndrome that was described some years ago at a conference which included experts on ICU. And this conference, believe it or not, showed that up to 56% of patients could have persistent symptoms of mental illness. So many of the patients were not getting back to work within 6 months, and this is a very major problem for post-ICU, and COVID-19 patients are clearly, many of them are post-ICU. So long haulers, there's going to be a high percentage or high absolute number of long haulers because of the sheer numbers of COVID patients. And even if we look at things like 20% of patients that come out of ICUs, if you're talking about, hundreds of thousands of patients coming out of ICUs, then you're looking at a big problem.
What I heard you say is that a normal COVID episode would be in the 4 to 12 week range, and anything after that might be considered long haul?
No, there's actually a acute COVID phase, which is mostly considered up to 4 weeks. So if you have acute COVID, up to 4 weeks. And then this ongoing symptomatic COVID, which would be considered sort of a long hauler because that's considered 4 to 12 weeks. And then after 12 weeks is sort of the post-COVID long hauler. So there's the acute long hauler, usually up to 12 weeks. And then the post-COVID, meaning they're not infected anymore, but they've got symptoms that persist after 12 weeks. So the long hauler could be considered anybody after 4 weeks. But what we're saying here is that it's sort of expected. Many patients that are symptomatic for longer than 4 weeks. So it's not clear that you're going to call them all long haulers when the expected outcome is that you still have symptoms after 4 weeks. So again, there's no real definitions, but what we're talking about is outpatient. We're talking about past 12 weeks, possibly inpatient all the way up to 12 weeks.
Thanks, Dr. Votto, for that great overview. Do you at the Hospital for Special Care have a framework that you're using to help distinguish long-haul patients from other COVID-19 patients?
The literature suggests that acute COVID lasts usually up to 4 weeks, and that even though we see symptomatic patients past that's mostly the acute phase. Now, long haulers who have persisting respiratory symptoms often can last up to 12 weeks. And then we consider anybody past 12 weeks as the typical long hauler who is seen in post-COVID clinics and is seen by primary care physicians who are still complaining of symptoms, which are typically the ones I mentioned before: fatigue, dyspnea, chest discomfort, and cough, lasting well over 12 weeks and often 6 months to a year.
That's very helpful. I think the listeners will find that very useful for the upcoming remarks as well.
The only thing I was going to mention is that there's actually a study. I don't know if the acute cares want to know this, but only 13% of hospitalized patients were symptom-free at 60 days post-COVID. That means 87% of hospitalized patients were still symptomatic 2 months after their COVID. So in other words, if you were hospitalized with COVID, you almost are guaranteed to continue to have symptoms for 2 months. And then the rehospitalization rate is about 10%. So patients that are in the hospital discharged, at least 10% of COVID patients are rehospitalized.
Okay, I think those factors are helpful. Again, that just kind of fleshes out the need for the LTAC role.
Yeah, I think so.
John, thank you. The long haul description was very helpful. I think it might also be worthwhile to share a little bit about what RML has been experiencing here in Chicago in the last several weeks. What we're seeing is very few numbers of patients that are being admitted post-COVID on ventilators. What we're finding, though, is that about 40% of all of our admissions today across all three of our programs are post-COVID patients. And very similar to how John described the patient population in Connecticut, we're seeing that these patients have higher complexities. They have higher staffing ratio requirements. Many of them are coming to us in restraints. Many of them are coming to us with significant medication challenges that we're having to deal with as they go through the process of being taken off of certain medications. Our length of stay is increasing almost 2 weeks in the last 3.5 months for these post-COVID, what I would call sort of the long-haul patients. And what we're seeing is fewer discharge options. And I think that fewer discharge options is also contributing to the backup in the system still. Because as we are unable to discharge patients that could go to a skilled nursing facility or to other aspects of the post-acute sector, we're unable to discharge these patients to the next setting to free up a bed to allow the referring hospitals another opportunity to move a patient through the system. So there is a logjam in the system that is still in place today, and many of these patients are post-COVID and COVID recovery patients that we're dealing with in Chicago.
Right, that's important. So memory issues are said to affect about 20% of the COVID patients that are in the ICU. So those always impair discharge, as does high flow oxygen. So those two things generally always impair discharge options. Prior to COVID, that was an issue, and it will be an issue with many of the COVID patients. So I agree. That's an important point. Discharge options is important.
Then there's that, what do we call that middle category, the 4 to 12 week patient?
Well, they call it ongoing symptomatic COVID. It's sort of persisting acute COVID. It's persistent acute COVID because nobody wants to call too many things chronic or long hauler until you've reached, 12 weeks. At least that's what the review of the literature told me.
But that can give us terminology also for Jim, so that we're consistent. So acute COVID, persistent COVID, and then long haul COVID.
But that's after reading a bunch of articles, so you kind of conglomerate everything because there's no consensus. Pretty much most people would say long haulers are greater than 12 weeks. If you're still symptomatic, you're a long hauler.
But those labels, acute COVID, persistent COVID, and long haul COVID, are easy enough and intuitive enough. So yes, I did think that was super helpful. Dr. Votto, can you also speak to the clinical competencies that are unique to LTACs with regard to long haul patients?
Probably LTACs are almost uniquely set up for this type of patient. The clinical competencies that you need with COVID-19 seem to be, the vast majority of these patients need respiratory support. And high flow oxygen, as Jim Prister was getting to last time, less use of invasive mechanical ventilation and more use of non-invasive mechanical ventilation and high flow oxygen became the trend over the evolution of this disease. And so LTACs are fairly uniquely set up with high flow systems so that most LTACs can deliver high flow oxygen. We are competent in respiratory care unless we have lots of respiratory therapists as a proportion of our employees. We essentially all employ pulmonologists to some degree or another or contract with them. And we have vast experience with invasive and non-invasive ventilation, as well as, like I said, high flow oxygen delivery and weaning from mechanical ventilation or even weaning off of non-invasive ventilation. The other thing that seemed to be inherent in this population is generalized muscle weakness, which goes along with post-ICU syndrome. That is post-ICU myopathy or polymyopathy, as they're called. And so physical and occupational therapy and speech-language pathologists are fairly important in the recovery of these kinds of patients. So we think that those competencies are needed in this population. The other thing that Jim had mentioned was delirium, which is very common in the post-ICU syndrome, which is common in the post-COVID syndrome. And, there's been studies that suggest that post-ICU syndrome, 56% of these patients that come out of ICU have post-ICU syndrome at even up to months afterwards, and that delirium is a predictor of post-ICU mental health abnormalities. And so when you see this type of patient, you want to address that. Some LTACs like ours have psychologists employed, and so we actually, during our treatment of the COVID patients in our COVID unit, we had one of our clinical psychologists see basically all the COVID patients that were admitted to do a determination as to whether they had post-ICU syndrome, some delirium, or just the usual anxiety and depression that you get from having a severe illness. So I think that those things, I wouldn't pretend that all LTACs have those capabilities, but they all have the first ones that I mentioned.
To begin to wrap up our podcast, let's look down the road a bit. As the broader health system begins to consider the post-pandemic landscape, what does the LTAC experience so far tell us about their role for the future? Let's kick off with Dr. Votto's take from a clinical perspective, then we'll transition to Jim's take with more of an infrastructure focus. Dr. Votto?
One thing that the acute care hospitals and the broader community should know is that LTACs can handle most acute care hospital levels of care, including most ICU level patients who are immediately post life-threatening situations. So in other words, we can handle most patients that are not having an acute heart attack or evolving through their illness, but that immediately post the acute illness, that we can handle most of those levels of care. And then if you asked what should states look at in clinical planning, I would say that any state healthcare planning, especially the emergency planning, which they all do, should include LTACs in their pandemic emergency plans or ICU overflow plans. Just as an example, when 9/11 occurred, we were in line to receive some of those patients because we had an emergency plan and an overflow plan, even from New York to Connecticut. And so there was a plan that was outlined, not specifically for a terrorist attack, but for overflow from ICU needs. And I think that's something that state healthcare systems should look at.
Great. Thank you, Dr. Votto. Jim, what's your take on this question of what the future might hold for LTAC?
Rochelle, thank you for the opportunity to talk about this. I think it's a very important topic for us to bring forward across the communities that we're in, both at a local, regional, state, and even a national basis. I think by using the acronym LTAC, LTCH, we often forget that we are a hospital. And as I reflect back on the needs of the last year, I think LTACs rose to the occasion in adjusting the services that we were providing, adapting to the daily and ongoing challenges of pressure that we were getting from our referral hospitals. 95% of all the patients that were admitted to RML over the course of the last year came right out of an ICU. And I think it's important for us to really keep that into context because as you made known in your opening statement, about 5 years ago, there were 470 LTACs. You indicated today there are 360 LTACs. There has been an extreme focus on LTACs being a very costly part of the post-acute industry. I think what we've demonstrated over the last year is that LTACs are an essential part of the strategic reserve from a community perspective, and we have to be viewed as such. We have the expertise, as Dr. Votto indicated, we have the clinical capabilities, we have the infrastructure in place. We are hospitals, and I think we need to look at LTAC specifically as a different type of institution than maybe we were evaluated a few years ago. We have an opportunity, I think, to set really an agenda, if you will, that we are instrumental in the management of this very highly complex, fragile patient, not just from a COVID management perspective, but also from a situation where there are non-COVID patients involved. And I think that's something that we should be thinking about as a small part of the industry, but I think it's more important that the larger healthcare industry views LTACs differently moving forward than they have over the last few years.
We're aware that significant funding on post-COVID research is being allocated at this time to help prepare for future pandemics. What role should LTACs have in this research? For instance, Dr. Votto, you already cited earlier when we were offline some of the early findings. You were mentioning that the patients coming out of the general acute care hospital, of those, only 13% were symptom-free after 60 days, as well as you cited the rehospitalization rate. You could cite that as an example and perhaps tee up other issues that should be looked at. And then, Jim, you could build upon that as well.
Rochelle, your question about the future role of LTACs is also brings to mind an additional factor that I think we need to put forward at, again, the state, regional, and national levels, and that's really an opportunity for others and or LTACs to participate in research. Early on in the pandemic, when it first was initiated in early 2020, and unfortunately, the impetus was really not on the LTAC's role. It was really trying to create sort of that mass amount of capacity in the system. We reached out and we actually participated in an NIH-funded research to identify the effectiveness of vent COVID patients once they got to RML, and that research is still being conducted today. I think there's that opportunity for us to identify long-term, what's the role of the LTAC potentially in another pandemic? What's the role of the other post-acute providers as we move forward? There has been significant change in the post-acute industry, in management of patients across the post-acute space. And I think LTACs as a particular area of interest, we have a lot to offer referring hospitals. We have a lot to offer our communities. And the intensity of the patients that have been treated in LTACs across the country over the last year has been extremely high, and I believe a very valuable resource for referring hospitals.
We're aware that significant funding on post-COVID research is being allocated at this time to help prepare for future pandemics. What should LTAC's role be in that research effort? Dr. Votto?
From the LTAC perspective, I think we have to look at the clinical scenarios that are presenting now with this particular pandemic, as it is not typical of the post-ICU syndrome has been described in the last decade or so. And I think that what we need to do is look at from the clinical perspective, the research on post-COVID syndrome, which we know there will be a lot of it, but also to the extent that these patients can get back to work, which has been shown in the post-ICU population to be up to 50 to 60% are not back to work in 6 months. And we should know that data on the COVID population is whether these people end up getting back to work, getting back home, where the discharge options, as Jim Prister mentioned, and what will be the difficulties in the future and discharge options and follow-up of these patients. And the idea of post-COVID clinics, which is popping up in many communities, is a good idea, which would be multidisciplinary, including psychologic follow-up, which is going to be a major factor. So I think we should be pursuing those, and the LTACs can be certainly a part of that and should be a part of that, as we will get the most severe cases and end up following those.
AHA is taking steps to address and improve equitable access to COVID testing, treatment, and vaccines. Jim, can you share your experience from that perspective relative to your Chicago scenario?
Be happy to, Rochelle. Over the course of the last year, RML has admitted over 200 active COVID positive patients really at both of our locations. Approximately 75% of all of those patients were in the Black and Brown communities. It came from the Black and Brown communities. It has been disproportional in terms of the impact that COVID has had on these patients. I am very happy to say that the outcomes for all of our patients that came to us with COVID positive are actually better than our historical control group, if you will, of patients that would present to us on ventilators in the past. So about 75% of those patients, 75 happens to be the number, were weaned from the ventilator and were able to get back to the post-acute environment, either into skilled nursing facilities, rehab care, or it is very interesting, though, as we look at the impact. It has been a challenge for our Black and brown patients that were coming to us, trying to get care delivered in their homes, often very difficult. Trying to convince caregivers to go into homes of potentially COVID positive patients was very challenging in the early days of the pandemic. It has since gotten better. We're seeing much more lessening of restrictions and barriers to providing access to these patients really coming from the Chicagoland area. And it really is very, I think, encouraging to see that access is really pretty widely available now. We do not provide outpatient services, so I can't comment on the vaccine distribution network. I know there's very active distribution networks in and around the Chicagoland area, and we would be happy to learn more about that and to see if RML can be a valuable resource in the delivery of the vaccines in the future. But that's not something that we do today.
Thanks, Jim and Dr. Votto. We appreciate your leadership on this really important challenge on the long view for LTACs. And we appreciate your time and expertise. And to our guests, thanks for listening and learning about LTACs.